Good morning, good afternoon, good evening po sa lahat. Welcome to our 170th episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who have just discovered us today, welcome po. At sana po marami po kayong matutunan sa very not so popular na topic pero we feel is very, very important to be discussed. And it is about trophoblastic diseases. It's a topic of utmost significance with far-reaching implications for the health and well-being of expectant mothers. Isa na po dito, ang high.TD4 mole, also locally known as Kiawa, and gestational trophoblastic neoplasia, often causing bewilderment amongst the general public. These rare conditions could be potentially perilous, but often shrouded po, very technical jargon, may be intimidating sa mga layperson po. So for today, sana po ay maliwanagan po kayo sa ating mga pag-uusapan for today's topic. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And always looking forward to our Fridays because it's my pleasure and honor to host this program together with our adjunct research faculty at the National Telehealth Center. Also, international renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie?
Hi, Raymond. Good afternoon. Magandang hapon po sa inyong lahat. We welcome you to Stop COVID Deaths, especially those of you who are with us on the live broadcast in Zoom. And I know some of you are live streaming through TV UP YouTube channel, as well as the UP System Facebook page, TV UP Facebook page, the Stop COVID Deaths Facebook page, and of course, those are watching through TV UP Signal TV channel 101. And for those who are on the playback, we also would like to welcome you. We know not everyone can join on a Friday noontime webinar, but we do see a lot of you coming back to the videos that are available on YouTube. So our topic for today is very interesting. Sabi ko nga, Raymond, kanina, parang this is about mukhang buntis, pakiramdam buntis, lumalaki yung tiyan, pero hindi siya buntis. So we are going to talk about trophoblastic diseases, and we have, as usual, gathered the best experts in this field. And Raymond's going to introduce our speakers. Raymond, go ahead.
Thank you, Dr. Susie. For today's webinar po, we have two main presenters and one reactor po. For our very first presenter, she's currently the board secretary of the Philippine Society for the Study of Trophoblastic Diseases, also the training officer of the UPPGH Department of OBGYN's Division of Trophoblastic Diseases, Dr. Mariel Febi de Ramos. Our second main speaker is the past Assistant Secretary of the Philippine Society for the Study of Trophoblastic Diseases, also faculty member of the UPPGH Department of OBGYN, Dr. Mariel Nevado-Gammad. And for our reactor, hindi po siya kaila sa inyo dahil naging co-host ko po siya during the past few weeks, Dr. Agnes Soriano Estrella, who is the immediate past president of the Philippine Society for the Study of Trophoblastic Diseases, also currently the chief of the Division of Trophoblastic Diseases at the UPPGH Department of OBGYN. And finally, the synthesis and closing remarks will be delivered by the head of the Office of Expanded Education and Training at the UPPGH, Dr. Stella Marie Jose. Dr. Susie.
Thank you very much, Raymond. And we are truly very thankful and grateful for all our experts who take time to be with us, to explain, to share their knowledge and information. And stay with us because I know we are all going to learn a lot about trophoblastic diseases. So as you've seen in our opening billboard, we have transitioned to broader discussions. For those of you who have been with us from the get-go, which was, what is it, Raymond, 170 episodes ago ba?
170, yes, the 170th now.
Some of you have been with us for 170 times already, more or less. And we did start this webinar because we wanted to expand knowledge on something very new, COVID-19. But we did realize after that there are so many other topics in health that we'd like to cover. So Stop COVID Deaths is now covering many, many different health issues. And to start off, we know that you always want to be kept abreast of the latest news in health and medicine. And it's for this reason that we bring you the news update.
Okay, for our very first news update comes from the Philippine Star. The Department of Health has been urged by a popular, well-known infectious disease expert to procure the monovalent XBB vaccine. COVID, now an illness no longer different from other diseases, ani po niya, but still good to have the monovalent XBB vaccine to protect senior citizens and those with comorbidities. The current circulating COVID variants are the lineages of XBB and not anymore BA.4, BA.5. The bivalent vaccine that we have right now will not produce antibodies specific against XBB and will not be able to protect anyone exposed to XBB-related variants. And according to the Department of Health's biosurveillance report, the latest po, no, showing that from August 2023 onwards, XBB and its sublineages were the most detected variants, comprising greater than 92%, almost 93% of samples sequenced with assigned lineages. So if we could procure ito pong monovalent XBB vaccines to be able to be given sa mga elderly, immunocompromised, those with comorbidities, then we'll be able to protect these vulnerable populations. Dr. Susie.
Yes. On the other hand, in a monumental achievement, Bangladesh has become the first country in the world to be officially validated for having eliminated visceral leishmaniasis, commonly known as the Kala-Azar disease. This milestone results from dedicated efforts of different sectors, including the government of Bangladesh and the World Health Organization. Kala-Azar is the most severe form of leishmaniasis. It is a life-threatening disease caused by Leishmania parasites that are transmitted by infected female phlebotomine sandflies. It affects the most disadvantaged rural communities, among whom poverty, poor housing conditions, malnutrition, genetic factors, and other infectious diseases are major risk factors. Kala-Azar can be fatal in over 95% of cases, and so it is indeed an achievement to eliminate this particular form of infection. And that's our news for today. We'll be back next week with more updates on the news update. And we are back, Raymond. Kyawa, no? Tawag nila kyawa.
Yes, that's true. That's true.
I remember this back in the day. Si Stella was one of our residents in OB. Ano yan no? Parang yung ultrasound niya, parang merong hindi baby yung nasa loob Di ba mukhang ubas? You remember?
That's true, that's true.
Yeah, so I think we have a lot to learn. It's a bit of a refresher for us. And at this point, we're going to get some feedback from people on the street. You want to introduce that, Raymond?
Thank you, Dr. Susie. So for those who are joining us for the very first time, we usually set our discussion into context by watching this very short video produced by the webinar team called Person on the Street Videos. We interview common folks on the street to gain an understanding of what they already know about the topic at hand before we even go to the webinar proper. So the questions that we pose are as follows. Ano po ang alam ninyo tungkol sa mga sakit na tinatawag na trophoblastic diseases? Sa palagay ninyo, paano ito nakaaapekto sa kalusugan ng mga buntis? May narinig ka na bang mga karanasan o kwento tungkol sa mga ito? Maaari nyo ba itong ibahagi? Ano ang mga palagay ninyong mga sintomas o senyales ng trophoblastic diseases? Alam mo ba kung paano ito nadadiagnose at ginagamot? At alam nyo bang may National Referral Center para sa mga pasyenteng may gestational trophoblastic disease? Please watch this.
Hindi ganun ka-broad yung idea ko sa trophoblastic disease, pero aware ako na isa siyang tumor na tumutubo sa uterus ng mga kababaihan during the early stage of their pregnancy.
Wala po. We call HMO in Gynecology, Obstetrics. Well, what I know is it is a premalignant lesion. It is what we call in the common language a pseudo-pregnancy called KEWA, right? And it can mimic pregnancy, but you can discover it through an ultrasound with a pathognomonic sign of a grape-like structure.
Hindi ko alam kung ano yung epekto niya sa pagbubuntis ng babae o sa sanggol. Pero alam kong masama kasi yun nga, isa siyang klase ng tumor.
And it is, as I have said, it is a premalignant lesion. It's the overgrowth of the trophoblasts.
Wala pa akong na-encounter na may kakilala ako na nagkaroon nito, lalo na buntis pa yung mga apektado.
Hindi pa po.
Oh yes, of course. There are so many gestational trophoblastic diseases. Aside from the HMO, we have also the so-called dermoid cyst, which is a cyst of the uterus. Usually the ovaries. This is the ovaries that when you open it, it will mimic the formation of hair and teeth and all those embryologic cells that grow during the growth and development of the embryo.
Ang alam kong sintomas ng sakit na ito ay high blood or siguro frequent headache, ganun.
Wala pa po akong nababalitaan.
Wala akong idea kung paano siya ginagamot or paano yung pag-diagnose nitong sakit na to.
I heard of it, but I'm not sure about it. Probably this is a project of the Philippine Obstetrics and Gynecological Society that assists mostly those people who are suffering from these trophoblastic diseases.
Tungkol sa center, wala akong alam na mga national center na National Referral Center para sa mga sakit na ganito. And if meron man, edi mas okay kasi mas magpapagamot agad yung yung mga taong may ganitong klaseng sakit.
Okay, thank you so much, TVUP. What did you think of it, Dr. Susie?
Well, it seems that we have to, what should I say? We need to listen to the updates from our experts. Mukhang hindi masyadong clear sa ating public kung ano itong mga trophoblastic diseases. And it's just perfect that we've got so many great speakers today. So it's going to be a refresher for some. And for those who haven't been exposed to it, it will be new material, mukhang new material for some of our listeners. Anyway, Raymond, before we go into our presentation proper, you have some housekeeping, no? Usually
Yes. Thank you, Dr. Susie. So for those who are asking, we've already sent out our certificates of attendance for all 169 episodes. So please let us know if you did not receive your certificates and you feel you should have, please email us at stopcoviddeaths@up.edu.ph. So for all those who are asking certificates of attendance, usually given to those who have watched at least 50% of the webinar duration. For our webinar today, we'll be having a standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. But before we delve into the webinar proper itself, we'll go into our fun quiz segment, which will be introduced by a short, cute intro video.
Hello! Hello! Hello!
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Raymond, nasa Little Mermaid pa rin. Palagay ko, dapat pumalit na tayo ng trolls.
That's true. We'll have something new by next week.
Okay.
Can we have it on the screen po? The Zoom poll as well as the Slido. Okay, so we're seeing it on the Zoom. We have two questions. For those who are in the Zoom poll, you'll be able to see that there are two questions that are seen here. But for those who are watching us in the playback, or those watching us outside of the Zoom, YouTube or Facebook, you can still participate in this fun quiz by opening up your browsers, typing it in the address bar, slido.com, and when you are prompted, you enter the code 6510096. That's 6510096 for you to be able to participate in our fun quiz. Our very first question here reads, what is the most common presentation of hydatidiform mole or kiawa? Is it A, vaginal bleeding? Is it B, abdominal pain? Is it C, pelvic mass? Is it D, nausea and vomiting? So we'd like to take this opportunity to greet those who are watching us from the Notre Dame de Chartres Hospital, Baguio City in Benguet, Oriental Mindoro Provincial Hospital in Calapan City in Oriental Mindoro, Vicente Soto Memorial Medical Center in Cebu City in Cebu, Malay Municipal Health Office in Malay Aklan, Zamboanga del Sur Medical Center in Pagadian City, Zamboanga del Sur, Southern Philippines Medical Center in Davao City in Davao del Sur. There are those watching us also all the way from Los Baños, Laguna, from Deca Homes, Loma de Gato, Marilao, Bulacan, University of Rizal System Health Services Unit. Maraming salamat po. From the province of Bataan, thank you so much. From the Bulacan Medical Center Department of Pathology and Laboratory Medicine, from the province of Cavite, from RPHS Annex 1, Antipolo, Rizal, from Diliman, Quezon City, ayun po, maraming salamat. For question number 2 reads, what is the primary mode of treatment for gestational trophoblastic neoplasia? Is it A, surgery? Is it B, chemotherapy? Or C, radiotherapy? Or D, multimodality? Greetings din po from those watching from New Sinai School and colleges. Also internationally, we are being watched po by our masugid po na taga-subaybay, our viewers from the Chuanin Hospital, Taipei City in Taiwan, Los Angeles, California in the United States, Island Hospital in Penang, Malaysia, Lunichi Ali University of Blida 2, Blida, Algeria, Taif, Saudi Arabia, Canadian Medical Center in Dammam, Saudi Arabia, and the University of Hail in Hail, Saudi Arabia. Okay, so we encourage everyone to participate po dito sa ating fun quiz, and we'll be introducing our first speaker for today. I'll be the one to introduce, Dr. Susie.
Sige, go ahead, Raymond. Go ahead.
Our very first speaker po, no? So moving on to the webinar proper, our very first speaker is Board Secretary of the Philippine Society for the Study of Trophoblastic Diseases. Also, Training Officer of the Division of Trophoblastic Diseases of the UPPGH Department of Obstetrics and Gynecology. Please welcome Dr. Maria Febi de Ramos.
Good morning. Good
Good morning po.
afternoon.
Go ahead po. Go ahead.
Dapat pala po lahat, no? So, a pleasant day to all our viewers. So, should I share screen?
Yes,
Yeah,
go
go
ahead.
ahead. You have the floor. Go ahead.
All right. Okay. So, once again, I am Dr. Febi de Ramos, and I'd like to thank the TVUP for inviting us to share about this special topic. So what I will be talking about in the next 20 minutes will be about hydatidiform mold. So what are the things that you need to know about hydatidiform mold? So again, I'm Dr. Febi de Ramos. So these are the objectives of my lecture this morning. So to be able to define what is gestational trophoblastic disease, to know the risk factors and the pathogenesis of the disease, and also to be able to recognize the clinical presentation, the diagnosis, and the management of hydatidiform mold, as well as the most important objective, which is to identify the risk of developing to malignant degeneration. So this will be the outline of my lecture. So to begin, gestational trophoblastic disease is a general term that is used to include tumors derived from abnormal growth of trophoblasts. So these lesions ranged from the benign to the malignant forms of the disease. So when you look at this box, no, so this is the classification, the WHO classification of gestational trophoblastic disease. So this is subdivided as follows. But for the purpose of this lecture, I will just be focusing on hydatidiform molds. Later on, my partner, the other speaker will be talking about gestational trophoblastic neoplasia. So what is hydatidiform mold? So when you say hydatidform mole or H mole, no, it is a non-viable, genetically abnormal pregnancy that actually results from an excess in the expression of paternal genes. It is an abnormal conceptus grossly resembling a bunch of grapes, so either with or without fetal components. So if you look at this picture, no, you'll see here that para siyang sago-sago, no, it's a bunch of grapes appearance. And microscopically, it may appear as an enlarged edematous and vesicular chorionic villi. So there are two types of H mole or hydatidform mole. It may either be a complete or a partial mole. So let's go about the pathogenesis. So first is why or how does a complete hydatidform mole happen? So if you look at this picture, no, so most of the complete hydatidform mole happens when there is fertilization of an empty ovum with a haploid sperm. It actually duplicates in itself and became the normal karyotype, which is the 46XX. But there is no maternal genes. In like a lesser incidence, there may also be like 2 sperms. But again, it fertilizes an empty ovum. Also again, resulting to a 46XX. So kapag complete hydatidform mole, it's more of diploid, no, and androgenetic. So there is no maternal component. On the other hand, partial hydatidform mole occurs when there is a fertilization of 2 sperms naman. So 2 sperms with a haploid ovum. So it's either the sperm may be 23X or 23Y, but it fertilizes a haploid ovum, resulting to a triploid naman. In contrast to the complete hydatidform mole, it's diploid. But again, in certain instances, it can also be just 1 sperm, but this is more of inactive or unreduced form, no? So 46XX na to begin with yung sperm, and again, a haploid ovum, which is 23X. So if it is a partial mole, since there is a haploid ovum, there is a maternal component, and you may also see a fetal parts, all right, in contrast to the complete hydatidform mole. So what are the risk factors? What happens, or are there people who are at risk to develop hydatidform mole? No, so a well-established risk factor is actually age, no? So in an incidence, they say that there's a J curve, no, wherein it is very commonly seen in extremes of maternal age. It's either very young among adolescents or to an advanced maternal age, 36 to 40 or even older than 40 years old. No, it is also has a relationship in terms of the egg, no, or yung ating quality of the egg. Of course, if it's very young, it's not really that good, as well as also if it is very later maternal age. No? Another established risk factor is if you have a previous hydatidform mole, or what you say a recurrent hydatidform mole, you will also be at risk to develop another hydatidform mole. Other established or other risk factors also include being an Asian, no, in terms of ethnic predisposition. So this is really commonly seen among Asians compared to those Caucasians in descent. In terms of nutrition, there have been studies about this, although really not that much proven, but there are still ongoing researches wherein they identified that a deficiency in the vitamin A, no, in the diet may also be a risk factor for developing hydatidform mole. So how does it present, no, and how do we diagnose a hydatidform mole? So the most common clinical presentation is vaginal bleeding. So to those who answer the fun quiz, you know now what is the answer of that question, no? But sometimes there are some patients who presents with passage of vesicular tissue. So that's a very important history that you may elicit in a patient. Kung meron ba nung lumabas na sago-sago, the picture that I have shown earlier, because sometimes they may also present as such. These patients also may have excessive uterine enlargement, meaning when you ask the history, they are just like 8 weeks amenorrhea, and then they think that they are just 2 months pregnant, and yet their uterus is very enlarged already. So that's also another clinical presentation of a molar pregnancy. Another thing is the presence of the theca-lutein cysts. These theca-lutein cysts are actually the ovaries that are hyperstimulated. That's why they become enlarged, no? Kaya parang nakakadagdag din siya in terms of the presentation of an enlarged abdomen. Later on, I will be discussing regarding some complications of molar pregnancy, and this may actually exacerbate the presentation, no? So they may also present with hypertension, hyperthyroidism, or even hyperemesis, no? They keep on vomiting, severe than the usual, and also pulmonary insufficiency. They also present with difficulty of breathing. So these clinical presentation are usually seen at the later age of gestation, no? So yung mga advanced na molar pregnancy. So how do we diagnose molar pregnancy or hydatidiform mole? So this is just the usual, no? They think that they are pregnant. So of course the pregnancy test is positive, but remember that in some instances, no, pregnancy test may also present with a negative result, but actually it is a false negative one. It is because there is a very high HCG levels that there will be a Poisson or hook effect. There is oversaturation, hindi nagkakaroon ng sandwich reaction. That's why nagkakaroon ng false negative result, no? So in this regard, sometimes if, for example, your patient presents with abdominal enlargement, no, and then hyperemesis, suka ng suka, and then you're really suspecting that she is pregnant, and yet pagka ginawa yung pregnancy test, it became negative. So the most important initial diagnostic test that we need to request, aside from the pregnancy test, is the serum beta HCG, or the human chorionic gonadotropin. This is actually stable, and you can actually keep the blood sample and store it for a later examination, especially if in your area it is not readily available and you need to send it out in the city, no? Kasi hindi nga siya sometimes ganun ka available to the regions. But what I want to share is that the serum beta HCG in a normal pregnancy peaks at about 8 to 10 weeks. That's around 2 months of your pregnancy, no? And it declines and plateaus at about 16 to 20 weeks. So we need to know that there are levels of serum HCG in a normal pregnancy. But when you look at this table, no, it will not actually reach more than 200,000 for that matter. That's why there are some studies wherein if in any particular age of gestation and the result of the HCG is more than 350,000, then it is more likely indicative of a hydatidiform mole. Because if you look into this table, it will not reach that high. Okay, so that's very important. So very high HCG, and then you will now suspect that it is a hydatidiform mole. So of course, as what I have mentioned earlier in the interview, another diagnostic study that should be requested is a pelvic or a transvaginal ultrasound. So of course, diba, lahat naman ng pregnancy, you will also request for a transvaginal ultrasound. If it is a complete hydatidiform mole, you will see this typical snowstorm pattern, no? So parang yung mga, imagine or remember the picture that I have shown earlier, medyo sago-sago, it looks like that. So it will also appear on ultrasound as such. So you will not see any baby. in contrast to a partial hydatidiform mole, sometimes, aside from those cystic components in the placenta, you can see a fetus and or sometimes a gestational sac or a yolk sac. No, so these are the sonographic features that you will see in a hydatidiform mole. The thicalotain cyst that I have mentioned earlier will look like this. No, it's a spoke wheel appearance. It's an enlarged ovaries, and this is because of the very high HCG levels. So there are other ancillary tests that you will need to request, and these are the following. So, of course, your patient will present with vaginal bleeding, so you will request for a complete blood count and a blood typing. There are some instances wherein at a later gestation, the one I've mentioned earlier, patients will present with preeclampsia or elevated blood pressure or also hyperthyroidism. So you will also need to request these tests, no, thyroid function tests, the renal and the liver function tests. You may also request for a urinalysis, of course, to check if there is infection or there is albuminuria, no, because preeclampsia may also present as such. Not all the time, but case-to-case basis, if you can see that there is bleeding disorders, or if you want to rule out any bleeding disorders, you may also request for clotting function tests. But what I want to emphasize here is also the need for a chest X-ray prior to the evacuation. No, so it's very important to have a baseline chest X-ray, because remember the complications that I've mentioned. Pulmonary insufficiency, these molar products may also deport to the lungs and may present as difficulty of breathing. So it's very important to really have a baseline chest X-ray. And also, since H mole, which I will later on tell, no, this is actually considered as a pre-malignant lesion also. So a presence of a pulmonary metastasis may also clinch to a diagnosis. So the gold standard is still histopathology. So everything that you will obtain should be sent out for histopathology. And there are some instances, especially at an early hydatidiform mole, wherein there is still little trophoblastic proliferation, so konti lang yung mga molar products, then it's very difficult for the pathologist to really also diagnose or conclude to whether it is a complete or a partial mole, no? So sometimes an immunostain may also be helpful to identify whether it is a complete or a partial H mole, because there will be significance later on in terms of monitoring. So the P57 KIP2 is an immunohistochemistry wherein you will request to identify whether it is a complete or a partial H mole, because complete H mole will be negative because this P57 is paternally imprinted but maternally expressed. So remember that your complete hydatidiform mole does not have any maternal component. So it will be negative for that. And it will be positive for a partial hydatidiform mole. In rare instances wherein even the histopath and the immunostain is inconclusive, abroad they usually do this cytogenetic and molecular biological examination if it's still in doubt. Okay, so just to give a summary in terms of the diagnosis, it is a combination of clinical presentation, the typical ultrasonographic findings, as well as the elevated serum beta HCG. And most importantly, the gold standard is histopathology. So let's now go on to the management. What do we do if your patient is diagnosed with hydatidiform mole? So I think that's one of the things that is not that clear. So as what we always educate or inform our students, there are cornerstones of management when you deal with hydatidiform mole. So let's go over this one by one. First, it's regarding the recognition and the treatment of its medical complication. Earlier, I have mentioned vaginal bleeding is the most common clinical presentation. That's why anemia is the most common medical complication. So these patients may come to you very pale, And then, of course, anemic because, of course, they already bled too much. So you need to correct the anemia first. And since this patient have very high HCG, they may also present with preeclampsia and hyperthyroidism. The hyperemesis gravidarum may also be secondary complication of your elevated HCG, which may lead to electrolyte imbalance. So these medical complications may be present, no, in a patient with a high DATD4 mole. So you need to identify all of this, like in any other emergency situations, or like in any other patients who come to the ER. So you need to identify first any medical complications and address all of these things. So while you're preparing your procedure, your definitive procedure, you need to give your antihypertensives. You also need to give your hyperthyroid, no? You need to start already correcting any electrolyte imbalance. And of course, you need to prepare blood and also correct the anemia while preparing the patient for the definitive management, which is actually molar evacuation. So it is very important that if a patient is diagnosed with high DATD4 mole based on the summary that I have given earlier, you need to educate or inform the patient that that should be evacuated or that should be removed, no? So there are two forms of molar evacuation. It can either be through a suction curettage or a hysterectomy with mole in situ. So how do we know which one should be the mode of evacuation? So actually, irregardless of the uterine size or even the age in particular, you can still do suction curettage. But there are some patients who already completed their desired family size. Remember, I have told you that one of the risk factor is advanced maternal age. There are some patients who come to the ER, 46 years old, multigravid, and diagnosed with high DATD4 mole. So hysterectomy with mole in situ will really be a better mode of molar evacuation, okay? But what's important is that you need to remove and not just observe, no? So there are some patients when they were diagnosed with just abortion, so they think that it will just spontaneously pass out. But it's different when it's a high DATD4 mole. You need to really evacuate. So when you say suction curettage, it is almost similar setup when you undergo completion curettage or dilatation curettage, except that there is a special suction tip wherein you will need to evacuate using and connecting it to a suction machine, okay? Because the uterus is very boggy and it's soft, so the mode of evacuation should really be careful, as you can perforate the uterus if you just perform just the regular instruments used in a completion curettage, okay? So this is how you do it. In terms of total hysterectomy with mole in situ, there are some advantages. So one is to decrease the risk for local invasion. And again, it also is a form of permanent sterilization. Of course, if the patient doesn't want to get pregnant again, it's better to already remove the uterus with the mole in situ. In terms of local invasion, of course, diba, sabi ko earlier, there is risk for another high DATD4 mole. So if you already remove the uterus, then there is really no there is really no more chance to develop another high DATD4 mole because you already removed the uterus. But remember that even if you perform a total hysterectomy with mole in situ, it is very important that you educate your patient that it does not eliminate the risk for post-molar GTN. So this post-molar GTN or gestational trophoblastic neoplasia will be further discussed later on by Dr. Gammad. This is the malignant form of the gestational trophoblastic disease. And HCG will still be important to monitor even if you already removed the uterus. So this is another cornerstone of management. So unlike any other abnormal or failed pregnancy for that matter, after you do the curettage, no, for example, normal abortion, you perform curettage and the patient already follow up and is well. It is totally different when you manage a hydatidiform mole, because the most important part is really the monitoring after you did the evacuation. Because as I have mentioned, it is pre-malignant. You need to know that there is risk for developing to malignancy. If it is a complete mole, it is as high as 15 to 25%. In contrast to a partial mole, lesser, 0.5 to 4%. Of course, those patients with signs of marked trophoblastic proliferation are at risk for developing the persistent disease or yung sinasabing malignant form. So this is one of the things that I want to really inform our viewers, no? The identification of those H-mold patients who are at high risk to develop to cancer. So if, for example, the initial serum beta ECG is more than 100,000, there are presence of thecal lutein cysts, there are the uterine size is larger than the age of gestation by more than or 6 weeks. For example, patient is just 2 months by amenorrhea, and yet the corpus size is about 20-week size. So that's more than 6 weeks difference. And if your patient is also on the older or the elder group, that is more than 40 years old, and of course, the medical complications that I have mentioned, if these are present, and if this is a recurrent hydatidiform mole, she already had a molar pregnancy before. So these factors are very important to identify, because these are the patients who are at risk to develop to malignant degeneration later on. Because there is such a prophylactic chemotherapy that we can offer to our patients. So if you look into books, no, it is described as prophylactic chemotherapy. So you give chemotherapy as a prophylaxis or chemoprophylaxis. Wala pang cancer, but you can institute already chemotherapy. So there is an advantage. It says that in literature, it will reduce the risk of post-molar GTN among those patients identified as high risk. But of course, there is a disadvantage. It may also delay the diagnosis and may also require further courses of chemotherapy if this patient will develop later on to GTN. Because even if you give your chemoprophylaxis or your prophylactic chemotherapy, it doesn't mean that it is 100% curable, or it is 100% sure that you will not develop to the cancer form. It will just reduce the chances for those patients identified at high risk, okay? It is not routinely given even, no, worldwide. So iba-iba kasi po yung stand in terms of the chemoprophylaxis. So what drug is commonly given or commonly administered is called methotrexate, no? Other institution may also give actinomycin, but what we give here in our country is the methotrexate, and it is administered parenterally or intramuscularly and not in oral form. And most importantly, it is just given as one course. When you say one course, it's just 5 days of intramuscular injection. So again, not all patients are given chemoprophylaxis, only to those patients who are at high risk. Even if, for example, your patient are at high risk, but there are contraindications, then you may need to defer and just counsel the patient what to do next. And this is monitoring, okay? Because serum beta HCG is another cornerstone that is very important. You need to really save money, invest for the HCG monitoring, because it's not really that cheap also. So, but if you educate the patient that it is very important that you need to have subsequent HCG monitoring, then they will understand. Okay, so how do you follow up the HCG? So first is after the molar evacuation, you need to request, and then every 2 weeks, remember? So every 2 weeks until normal. And the normal is less than or equal to 5 million international unit per ml. So based now on our latest clinical practice guidelines, the monitoring will be different between complete and partial H-mole. So if it's a complete mole, because we know that there is a higher risk for developing to malignant degeneration, then the monitoring should be every month once the HCG is normal for as long as 6 months. So you do not end until your HCG becomes normal. In contrast to a partial mole, once you already have a normal HCG, which is less than or equal to 5, you need to repeat it after 1 month. And if it is still normal, you already discontinue the surveillance. Okay? So the time required to achieve to a normal values depends upon the baseline HCG. That's why I said earlier, it's very important to really request for a baseline beta HCG level. If the levels will be millions, no, 3 million, 2 million, may mga ganong patients, then of course, there will be a longer time to really have a normal HCG. So that's very important so that we can already identify who among those patients will develop to GTN. So another thing is about contraception. So we need to inform the patient that even if there will already be resumption of ovulation or resumption of menstruation, it is important to start already with contraception during monitoring to ensure that the rise of your HCG is not because of any pregnancy or another pregnancy. Because if your HCG will be less than 100 already, the ovulation may occur in 5% to as much as 60% if the HCG is already less than 10. So you do not wait for the normalization of your HCG before you start your contraception. Commonly, no, in some patients, the median time for ovulation after a complete hereditary mole is about 9 weeks and even 7 weeks after a partial H-mole. Kasi 50% of the H-mole patients will have normal HCG after 2 months. But as I have mentioned earlier, it depends upon the level or the baseline HCG. Okay, so what can we start? Any low-dose combined oral contraceptive pill. It is the preferred method because it has an advantage of suppressing endogenous LH. But of course, compliance is very important. You need to inform the patient that they should drink daily. Another form of contraception that may be acceptable is a DMPA or implant. But of course, you need to inform them that they should watch out for breakthrough bleeding kasi sila yung mga nagsaspotting. Intrauterine device or IUD is not recommended until your HCG is normal already. There's risk for uterine perforation. So that may not really be a best way to give after evacuation. So with regards to the pregnancy, after molar pregnancy, they will also ask that you may allow them to get pregnant if you already have a normal HCG after 6 months after your normal HCG level. And it's very important that you need to advise them that an ultrasound should be done or a consultation should be done if they already suspect for another pregnancy because of the risk for another H-mole. So after 1 molar pregnancy, the risk for another H-mole is 1 to 2%. So higher if there are 2 molar pregnancies already. So for a summary, remember the 4 cornerstones of management as what I have mentioned, and also the counseling regarding beta HCG monitoring, regarding contraception, and subsequent pregnancies. Okay, so to that, I'd be happy to accept questions later. Thank you very much.
Ako, thank you very much, Dr. De Ramos. Beautiful presentation. Ang galing-galing. It's very clear. It's one of the clearest presentations I've seen on this topic. And I'm sure we'll see the appreciation of our audience, no? Napaka-logical, tsaka napakalinis ng pagkakapresent. So, maganda to, no? For our audience, I would advise you to share this video with your team, no? Especially those of you who are in general practice o mga nakikinig sa atin ng mga nurses or mga midwives, no? Kasi very comprehensive yung presentation. Thank you so much, Dr. Very well said.
Thank you.
Sige, Raymond, go to our next speaker.
Thank you, Dr. Susie, and thank you, Dr. De Ramos. Please stay on po. No, we'll have, I think there are a lot of questions naman po from our audience, not just here in the Zoom, but also outside in YouTube and in Facebook. So reminding everyone that if you are ready, you could put them in the Q&A box here in Zoom, as well as in the comment section of Stop COVID Deaths or TVUP Facebook pages, or in the TVUP YouTube channel. For our next main presenter, she is past Assistant Secretary of the Philippine Society for the Study of Trophoblastic Diseases, also faculty member at the Department of Obstetrics and Gynecology at the UP Philippine General Hospital. Please welcome Dr. Mariel Nevado-Gammad.
Good day. Can you hear me po?
Yes po, loud and clear. Go ahead.
Just share screen. Sorry, I cannot share screen yet. It says here you cannot start screen share while other participant is sharing.
Please try again, ma'am.
Here, can you see?
Okay. Yes, go ahead, ma'am.
Yeah.
There you go. So, good day, everyone, and thank you for that warm welcome. So, I am here, Mariel Nevado-Gammad, to discuss about gestational trophoblastic neoplasia. And thank you to TVUP for giving us this opportunity to discuss about this topic. So, for me, I will be discussing the definition of gestational trophoblastic neoplasia, the incidence, the presenting signs and symptoms, the diagnosis, management, the follow-up, and the prognosis of the disease. So, gestational trophoblastic neoplasia represents the malignant end of the spectrum of gestational trophoblastic disease. Dr. De Ramos already discussed the benign lesions, while I will be discussing the malignant parts. GTN is a clinical term that denotes a disease state in which there is physical, radiologic, and or biochemical evidence of invasive mole, choriocarcinoma, placental site trophoblastic tumor, or epithelioid trophoblastic tumor. GTN may occur after any type of pregnancy, but its incidence is 2,000-fold greater following molar pregnancies, no? So let's take note of that. Very important that we extract in the history if the patient had a history of hydatidiform mole. So the true incidence of GTN, more specifically choriocarcinoma, follows the same trend as hydatidiform mole. In Europe and North America, the reported incidence is 1 in 40,000 pregnancies, while in the Southeast Asia, it is around 3.3 to 9.2 per 40,000 pregnancies. Here, locally in the Philippines, the national prevalence rate of choriocarcinoma and other trophoblastic neoplasias have remained almost constant at 22.4 per 1,000 pregnancies. In the University of the Philippines Philippine General Hospital, being a tertiary hospital and a referral center, a higher prevalence for choriocarcinoma and other neoplasias has been reported at 4.3 per 1,000 pregnancies. So as I previously mentioned, GTN represents the malignant end of the spectrum of gestational trophoblastic diseases. So it includes the invasive mole, the choriocarcinoma, and the rare types placental site trophoblastic tumor or PSTT and epithelioid trophoblastic tumor or ETT. Risk factors for invasive mole and choriocarcinoma would include a previous hydatidiform mole and advanced maternal age. Like what I mentioned, choriocarcinoma is 2,000 times more likely to occur after a complete hydatidiform mole. So GTNs, it's a unique disease in that treatment may be instituted based on clinical presentation alone without the need for histopathologic confirmation. So what are the signs and symptoms? The most common clinical presentation is abnormal vaginal bleeding following any type of pregnancy, but again, more common in hydatidiform mole. Specifically for invasive mole, they may present with persistent bleeding even after suction curettage for a molar pregnancy within 6 months or less, as the villi invade the myometrium, hence the name, no, invasive mole. Other associated signs and symptoms include uterine enlargement, acute abdomen secondary to tumor perforation with the tumor invading the myometrium leading to intraperitoneal bleed, an infection from a bulky necrotic tumor. Also, vaginal metastasis must be considered in the presence of a bluish cystic vaginal mass. And in this case that you see a bluish cystic vaginal mass, please do not do a biopsy since this could result in intractable bleeding. Now, patients may also present with lesions from metastatic sites with no associated symptoms in the reproductive tract. Pulmonary symptoms such as cough, chest pain, dyspnea, hemoptysis, or any signs and symptoms of respiratory distress or pulmonary insufficiency may be indicative of pulmonary metastasis. Now, lateralizing neurologic signs may also be seen as an evidence of CNS metastasis. Therefore, a high index of suspicion is needed to avoid delay in diagnosis and treatment. So for the laboratory and imaging studies, like what Dr. De Ramos mentioned, is the serum beta HCG. That's the heart of gestational trophoblastic diseases. It is an excellent tumor marker, and this is one of the reasons why GTN is considered to be a treatable tumor. If you see here, we are very specific na serum beta HCG because the beta subunit correlates well with the burden of the disease, such that the higher the beta HCG, the more the severe the GTN is actually, no? Therefore, serum beta HCG should be obtained in all patients suspected of having GTN. Now, for the imaging, we request for transvaginal ultrasound with Doppler studies. As compared to a hydatidiform mole, there's no Doppler studies. In GTN, it should be transvaginal ultrasound with Doppler studies. This is used to determine the extent of the disease, to determine the degree of myometrial invasion, detecting recurrence, and evaluating good response to chemotherapy. Now, along with complete history and physical examination, the following laboratory tests should also be obtained. This would include your complete blood count with platelet count, blood typing, the urinalysis, the liver function test, and renal function tests. Now, other lab tests such as thyroid function test or coagulation parameters may be requested as necessary. Now, metastasis to the lungs is the most common in GTN, and this accounts for about 80% of GTN cases. Therefore, a baseline chest X-ray should be done to determine lung metastasis. A whole abdominal ultrasound is requested to check metastasis in the abdomen, primarily in the liver. Additional imaging studies such as chest CT scan and cranial CT scan are requested as deemed necessary. Later on, when I discuss the staging and prognostic scoring, you will better appreciate the importance of these laboratory and imaging studies. I would like to emphasize that histopathology is not mandatory in the diagnosis of gestational trophoblastic neoplasia, since the disease may be diagnosed on the basis of clinical, radiologic, and biochemical parameters. As previously mentioned, a serum beta HCG correlates well with the disease. It is an excellent tumor marker. It has a high sensitivity and specificity for gestational trophoblastic neoplasia. So now let's go on to the staging. All patients diagnosed with GTN should be staged and scored using the FIGO 2000 anatomic staging system and the WHO prognostic scoring system. Now, the FIGO 2000 anatomic staging system defines the extent of the disease, such that in stage 1, it is just confined to your uterus. In stage 2, it goes outside of the uterus but is limited only to your genital structures. Stage 3, now the disease extends to the lungs, but it may or may not have genital tract involvement. Okay, so hindi necessary. It's not necessary to have the reproductive tract, to have lesions also for us to be able to diagnose stage 3 disease. And lastly, for stage 4, all other metastatic sites. Now, the modified WHO prognostic scoring system predicts the possible resistance of the tumor to single-agent chemotherapy. As you see here, a score of 6 or less signifies low-risk disease, while a score of 7 or more signifies high-risk disease. If you will notice in our prognostic factors, 4 out of the 8 prognostic factors may already be obtained from the history, and this would include your age, your antecedent pregnancy, the pregnancy interval in months, and a history of a previous chemotherapy. If you will see here, I mentioned that one of the risk factors is advanced maternal age. So an age of greater than or equal to 40 would have a higher score. A term pregnancy would also have a higher score. And if the pregnancy interval is more than a year, again, this denotes a higher score. For the previous chemotherapy, usually this would account for the chemoprophylaxis that was given after the suction curettage of your hydatidiform mole. Now, the other factors may be obtained using your laboratory and imaging studies, and this would include the serum beta HCG, the largest tumor size, the site of metastasis, and the number of metastasis. If you look at this table, a serum beta HCG of more than 100,000 denotes a higher score. Like I said, it's a good marker and it correlates well with the disease. Largest tumor size, if it's more than 5 centimeters, again, higher. If you look at the site of metastasis, the lungs is not included here, no? So that would denote a score of 0. But if you already have a brain and liver metastasis, again, it's a higher score. Now, for the number of metastasis, you would count all lesions seen on your imaging studies. But you have to take note that we count the number of pulmonary nodules on the chest X-ray. If we do not see any pulmonary nodule in the chest X-ray, then that would be the time that we request for a chest CT scan. We only use the chest CT scan to stage the disease. We don't count the number of nodules in the chest CT scan. Now, if your chest X-ray shows lesions measuring with an aggregate diameter of 3 centimeters, that would be the time that we request for a cranial CT scan. Now, there is also what we call ultra-high-risk gestational trophoblastic neoplasia. It has been identified as any presentation of GTN that might be associated with early death within weeks of starting chemotherapy or poor long-term survival. Features would include high burden of disease, including a FIGO prognostic score of greater than or equal to 13, and other features would include suspected or histopathologic diagnosis of choriocarcinoma, multiple pulmonary metastasis or associated hemoptysis, brain metastasis, large volume liver metastasis, profuse vaginal bleeding, beta HCG of more than 1 million, and an interval since the last antecedent pregnancy of 2.8 years. So let us now go to treatment. So chemotherapy is the cornerstone of treatment of gestational trophoblastic neoplasia. So yun po, chemotherapy, no? So for non-metastatic or stage 1 disease and low-risk metastatic disease, they are almost always cured with single-agent chemotherapy. And the usual drug of choice is methotrexate. Now, combination chemotherapy in the form of EMACO or etoposide, methotrexate, actinomycin, cyclophosphamide, and vincristine is the accepted treatment for high-risk metastatic disease and stage 4 disease. Now, if you will see in the slide, there's the plus-minus surgery. No? This is the adjunctive surgery. And when do we do adjunctive surgery? It is when we need to remove a resistant or persistent focus. We do it to decrease the tumor burden, to control bleeding, to relieve bowel or urinary obstruction, and to treat infection. And the following operative procedures may be done. You can do a hysterectomy, or if you have a young patient that you would want to preserve fertility, you can just do a wedge resection of the tumor. We can do uterine artery ligation or internal iliac artery ligation. Thoracotomy is done for drug-resistant pulmonary nodules, a craniotomy, oversewing of an actively bleeding vaginal lesion, and selective arterial embolization. In a 10-year review of surgeries performed from 1996 to 2006 at the UPPGH, 37% of patients underwent adjunctive surgery, and majority of them, at 97%, they underwent adjuvant hysterectomy. So going back to this slide, I'd like to focus your attention on stage 4 disease with brain metastasis. So we give high-dose EMACO for these patients, and we can also give concomitant adjunctive treatment of radiotherapy or irradiation. Now, how do we monitor now or assess the response to treatment? This would include adequate response or 1 log fall or more than 50% fall from baseline, a partial response, which is less than 50%, a plateau, which is less than 10% fall or rise from baseline, and biochemical remission, which is 3 consecutive normal serum beta HCG levels. And once your biochemical remission is achieved, consolidation therapy or cleanup courses is given. What is this ba? These are additional chemotherapeutic courses given to address the remaining tumor cell population undetected by the current HCG assays. So if you have the stage 1 and the low-risk metastatic disease, you give them an additional 2 courses of the same regimen that you previously gave. For high-risk disease, you give an additional of 3 consolidation courses. And lastly, resistance, which is 2 plateauing values or 1 rise weekly serum beta HCG titer, or there is an appearance of new metastasis. For this one, you have to reassess again, perhaps do a metastatic workup, and most probably you would have to change the chemotherapeutic regimen to be given to the patient. Now, because of the possibility of recurrence or relapse, regular monitoring must be done after achieving remission. So how do we do this? We get the serum beta HCG monthly for the first 6 months, every 2 months for the next 6 months, every 3 months for the second year of follow-up, and every 6 months thereafter. So more or less, if you have GTN, you're going to have serum beta HCG monitoring for the rest of your life, no? And for those with intact uterus in their reproductive years, they are advised to avoid pregnancy during the first 2 years following biochemical remission. This recommendation is made to avoid confusion in the monitoring of the HCG if the patient gets pregnant. Also, it has been noted that those who get pregnant within the next 6 months have increased risk of abnormalities such as miscarriages and stillbirths. Therefore, we give them safe and effective contraception, and we usually give low-dose oral contraceptive pills. Also, we should advise these patients, since they receive chemotherapy for GTN, that they are likely to have early menopause. But prognosis for GTN is very good. The cure rate for low-risk disease approaches almost 100%, while for high-risk disease, it approaches almost 80 to 90%. And the overall 5-year survival rate for stage 1 disease is at 97.3%, while for stage 4, it is 61.9%. So GTN, it's very treatable. So we would want to catch these patients early in the disease. So in summary, gestational trophoblastic neoplasia represents the malignant end of the spectrum of gestational trophoblastic disease. Your history and physical examination your serum beta-HCG titer, and your radiographic and imaging modality are the ones used for its diagnosis. A high index of suspicion is warranted for women presenting with abnormal vaginal bleeding. And again, I would like to emphasize that histopathology is not mandatory for its diagnosis. A thorough knowledge of gestational trophoblastic diseases is needed in the local setting because of the reported high incidence in the country. GTN should be considered in a reproductive aged woman presenting with metastatic lesions from a still undetermined primary focus. Awareness of the presentation of these groups of diseases will enable prompt diagnosis and management. Proper referral may then be done for accurate staging, which will correspond to appropriate chemotherapy, adjunctive treatment if needed, and eventual cure. So I'd like to share this slide. I know it's kind of small, but this is the distribution of trophoblastic disease specialists in the Philippines. Medyo kaunti pa lang po kami, no? But suffice it to say, if you know of any trophoblastic disease specialist, yung pinakamalapit po sa inyo, and you have a suspected patient of having GTD, might as well refer these patients. So thank you everyone for your kind attention.
Oh, again, thank you so much for a wonderful presentation. I think from our first presentation, which was also very clear, and then now you have shown us that it can be it can become more severe or more complicated and does require referral to experts. So thank you so much, Doctora. Very nice. I see the reactions of our audience to your presentation. Raymond.
Yes, thank you, Dr. Mariel. So again, we'll please stay po for our Q&A. And before we go into our Q&A, we have one last expert. Literally, nagsulat po ng libro about it. She is immediate past president of the Philippine Society for the Study of Trophoblastic Diseases and currently division chief of the Division of Trophoblastic Diseases, the UPPGH Department of Obstetrics and Gynecology. Please give a warm virtual welcome again to Dr. Agnes Soriano Estrella. Dr. Agnes.
Thank you, Doc Raymond. Thank you, Doc Susie. First time for me to see you because I took over your job for some time.
Thank you so much. Thank you for that.
Thank you. So anyway, thank you so much to TVUP for giving us the opportunity to have this session. And of course, congratulations to my colleagues in the Division of Trophoblastic Diseases. I am such a proud mentor because they delivered such great lectures. And I hope that it's clear to everyone how important for us to diagnose HMO so that we can properly address and treat our patients, and more so for patients with GTM. So I remember a few weeks back when Ma'am Stella, when we were having some discussion as to the next topics for TVUP, asked me if we can have this session for TVUP. And I remember grabbing the opportunity immediately and saying yes to her, because I felt that this was a great opportunity for us to increase awareness, not just for our colleagues in the healthcare industry, but also to the lay. As mentioned in the POTS, I guess a lot of people really don't know about the condition. And if ever they know something about it, there may be misinformation. So we would like to correct that and increase the awareness. So as mentioned by my colleagues, gestational trophoblastic disease is truly a rare disease. If we look at it in the international perspective, there are a lot of literature already saying that it's rare, but if we look at the geographic distribution, it's quite common in the Southeast Asian region, particularly in Indonesia and in the Philippines. We have always been the two countries reporting very high prevalence for both hydatidiform mole and gestational trophoblastic neoplasia. And yes, the question is, why? We actually don't know why. There might be something in the genes. We know that the Indonesians are the closest race, to the Filipinos, so there's probably something racial here. They mentioned that it can be because of low socioeconomic status. And I believe that initially when I was in PGH because of the type of patients that we were getting. But when I went into private practice, I realized that probably it's not just the low socioeconomic status, because I started getting patients who were in the middle or high income group in our society. I was receiving patients who were doctors, lawyers, businesswomen, executives in the corporate world. So probably it's not just the low socioeconomic status. They mentioned about the diet, but amazingly, there was already a study done in the United States where they looked at the prevalence of GTDs all over the country. And, they included Filipinos who were raised there, who were born there, and yet they saw that there was still a racial prevalence. It was still prevalent among the Southeast Asian nations, even if they already grew in the United States, meaning to say that it's really racial. We don't know. There's probably something in our genes. So, as mentioned in the two lectures, the diagnosis is based on a high index of suspicion. We have to be aware that the conditions exist. Because if we don't even think about it, then it will be very difficult to diagnose the disease. I received referrals who were being managed by other subspecialties for such a long time already, and they did not even think of GTN because the patient did not present with vaginal bleeding. She had a term pregnancy, but she presented with so many metastases already all over the body, and they could not determine the primary. So the diagnosis was so easy. Just a pregnancy test will tell us that probably this is already a GTN. And with the widespread availability of ultrasound, diagnosis is made so much easier. So for hydatidiform mole, I think of the different types of GTDH mole is the one that's most common. It's the one that can be handled by any competent OBGYN. But what's important really is to tell our patients that H mole is not something that we just neglect. Dahil natanggal na yung H mole, okay na. Because now we realize that it can progress to a malignancy. Therefore, adequate monitoring after evacuation of the H mole is very, very important. So, ideally, an H mole, even if it's benign, can still be co-managed with a trophoblastic disease specialist. Please do remember that trophoblastic disease specialists are quite different from the gynecologic oncologists. We have a different training for it. So it is something that we have to take seriously because with H mole, patients can actually bleed to death. And we all know that it can progress to a malignancy. So adequate follow-up, measurement of the beta HCG for at least 6 months would already be good for the patient. Now for GTN, definitely this is something that needs a high index of suspicion because we want to catch the disease early. Dr. Gammad already mentioned that with a non-metastatic low-risk disease, it can be treated and survival rate is at 100%. So can you just imagine that? No, this is a type of cancer, but everyone with a low-risk disease can survive, can go into remission. I don't think any cancer would be able to say the same thing, 100% cure rate. So we want to be able to catch them early. Now, in our training, we made sure that we have subspecialists in various parts of the country. Dr. Gammad already showed you the distribution of our specialists all over the country. There's just konti lang po kami. There are just at least 50 of us practicing, but at least we have a subspecialist in major key cities in the country. So I hope that you would be able to refer to them once you have a patient with suspected trophoblastic disease so that we can manage them and give them great future. Kasi pagka po GTN, hindi kailangan tanggalin ang uterus. Remember, these patients are at the prime of their reproductive career. But we don't have to remove their uterus. We can just give chemotherapy and they can still have their reproductive function earlier on. So they can still be very, very good members of our society. So another reason why I wanted this webinar is not just to create awareness for the disease, but to create awareness that there is actually a National Referral Center, which is the Division of Trophoblastic Diseases in PGH. And we are proud of this because we are the only training program all over the world, not just in the Philippines, specializing for the training of trophoblastic diseases. So if there are difficult patients already, even our colleagues in the provinces refer to us so that we can manage our patients properly. So I hope that this particular webinar or session was able to create awareness for all of our colleagues so that we would be able to catch the disease early for better prognosis for our patients. Thank you.
Oh, thank you so much, Dr. Agnes. Another wonderful response. Oh, 3 powerhouse doctors telling us about this. I think, again, I'm recommending to our audience, please share the recording with your team, with other people, because it's a very rare occasion to have them. And there is so much to learn about this. So maraming salamat, Agnes. I found it very interesting that Philippines and Indonesia have high rates, no? So I think it's something that all of our frontline workers need to be more aware of. Thank you very much. Raymond, go over to you.
Thank you, Dr. Agnes, for that excellent reaction. And would like to ask at this point our panelists to switch on your videos so we can prepare for the Q&A session. And as you are doing that, we'll take a very quick break for a special public service announcement today.
O sige na anak, parang kagat lang ng langgam. Kantik o yung kumikiliti lang? Ito naman parang hindi ka pa nababakunahan dati. Akala ko pa naman brave girl ka. Nakakahiya na kay Doc.
Okay lang po, nanay. Ay, ang cute naman ng shirt mo. Favorite color ko rin yan.
Doc, favorite ka rin po ang color nito. Pero ayoko po ng red huntik. Masakit kumagat at takot rin po ako sa blood. Magtudugo po ba ako sa bakuna?
Ah, hindi. Walang dugo sa bakuna. Konting pisil lang, tapos na.
Kakasugat ba ako, Doc?
Hindi ka magkakasugat. Lalagyan lang natin ng plaster pagkatapos para safe. Di ba nabakunahan ka na rin ng contra measles at chickenpox dati? Parang ganun lang din ang bakuna para sa COVID-19.
Natatakot pa rin ako, Doc.
Alam mo ang secret sa pagiging brave. Hindi ibig sabihin na wala kang kinatatakutan. Kundi, kahit natatakot ka, hinaharap mo pa rin ito.
Okay. Ready na po ako, Doc.
Una, pupunasan ko muna ng bulak na may alkohol ang braso mo. Okay? Tapos, mabilis lang na konting... Ayos! Tapos!
Tapos na, anak. Pwede mo nang buksan ang mga mata mo.
Nay, sabi sa inyo, brave girl na po ako eh.
O, heto ang prize para sa'yo, ha? Wow! Bagay sa shirt mo. That's the color of bravery.
Color rin yan for love.
Thank you, Doc. Thank you, Nay.
Dahil ako po ay mahal ninyo, nagpabakuna na ako.
Kaya mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many creative outputs of the webinar team to push for COVID-19 vaccinations. So please share this video clip in your social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. Okay, Dr. Susie, let's start the ball rolling with the first question.
Okay, great. So, I was thinking while I was listening to the presentations, because I actually had an ectopic pregnancy many years ago. But I wanted to ask about the psychosocial part of the management, because most of these women actually think they're pregnant, and then they find out that they're not. pregnant, so there's kind of like a loss there, or plus I don't know how the families or the husbands react. So maybe we can ask each of our doctors to talk about how to manage the feelings or the emotions of the patients. Let's go with Dr. De Ramos muna siguro. She's nodding her head, I can see.
Hello. Yes, so that's a very wonderful question because as what you've said po, Dr. Susino, medyo nalulungkot sila. They're quite sad that they think that they're pregnant. But every time we counsel them that this is just a benign, for example, for a hydatidiform mole, we advise them that this is just a benign disease, and monitoring is just very important, and you can still get pregnant with a normal pregnancy afterwards. So they usually accept it naman. No? So it's really more of the informing them the course that after monitoring, not all will develop to cancer. So they get to accept the case, and involving or counseling the family is very important. So as we always talk nga among ourselves, no, kapag ka nagkaroon ka ng isang H-mole patient or a GTN patient, minsan pasyente mo na rin yung lahat ng mga kamag-anak kasi they're very scared to really consult another doctor. So we just really need to advise them and of course assure that they will have a normal pregnancy later on. So there's still a possibility to have a normal pregnancy. Probably it's a different thing kapag ka-GTN naman eh. No? So iba din yung approach to counseling. But in terms of hydatidiform mole pregnancy, we just need to assure them. And most of them will become really fine.
Thank you. Dr. Gammad.
Yes, ma'am. So Dr. Febi talked about H-mole. No? For GTN, like what she said, when we have these patients, it's like, and our family is your patient already. And what, as the specialist, what we try to do is to make them understand what their disease is. And we present to them also the cure rates, the overall survival, the plans of management, and we also inform them that their reproductive outcomes, as long as they have the intact uterus, more or less, they're going to have a normal pregnancy. During what I notice is that during the course of the treatment, it's up and down yung moods nila. Pag they see that they have a good response, masaya sila, pero parang pag medyo bitin dun sa 50%, nalulungkot. But when we explain, not just to the patient, but also to the caregiver. Usually po kasi yan, may 1 or 2 na kasama in the hospital, no? They appreciate that. So they become more compliant with their treatment because they have something to look forward to, because they know that cure rate is good. Another thing is what I noticed in the division now, we're more proactive in identifying patients who might need help. So we try to refer these patients early on to the psych department. So we work hand in hand with other departments. We do multidisciplinary management for these GTN patients. Aside from that, actually, I'd like to share our GTN patients. They have this tropang tropho. They have their own group already. Wherein they find support, mga kapwa ko, because they yes, and you would see them, they would compare their HCGs, how many cycles they've had already, if they needed to shift cycles. So it's not just support from the family, from the doctors, but among the patients themselves. Parang sila na po yung nagkaroon ng initiative to form their own group and create awareness among each of them. Minsan, you would see them supporting each other, naghahanap po ng mga gamot because it's kind of difficult to find the therapy. So sila rin po, nagre-refer sila sa isa't isa. So we see that also in our patients.
Wow, that's a very inspiring story, no? I think because in this particular case, it's not just getting sick, but it's having something and then realizing it's something else, no? and knowing that you have other people who are going through the same situation. Agnes, what is your insight on this, the psychosocial part?
For the HMO patients, not really much of a problem compared to GTN. Of course, as you mentioned, Doc Susie, no, it's medyo nakaka-depress for some patients because you think that you have a pregnancy, you have nausea and vomiting, you have an enlarging uterus already, only to find out that it's not. But once we explain to them that the prognosis is good, we just have to halt the pregnancy just for 6 months. And I emphasize to them, 6 months na nga lang ngayon dati 2 years. So at least we have lessened it already. And the chance of another HMO is also very, very small. So for as long as we tell them that prognosis is good, the recurrence is also very low, they kind of accept it. Medyo may problema dun sa mga 40 plus and still wanting to get a pregnancy. Medyo may problema dyan. More support is needed. Sometimes I have to refer them for counseling because it really strikes them. And it's something that, you know, the OB-GYN may not really be very good at. They might need some professional help. And most of my patients acknowledge that. Ang maganda po kasi ngayon sa era natin, hindi na tayo nahihiya when we say that we need a psych consult. Not like before. Pagka sinabi mong psych, ay loka-loka.
Yeah.
Hindi na ganun ngayon We have become more open to the fact that some people need psychological help. For GTN, that's another thing. We treat our patients for a lifetime. Once they become our patients, it's a lifelong relationship already. And we're not dealing with just the patient, it's the entire family. Because it's a very intensive treatment. Imagine receiving chemotherapy every week. No, it's not like the others now. One session, outpatient, then see you next month. Sa amin po, every week, we see them for chemotherapy. For low risk, every day po yan, bumabalik-balik sa amin. So very intensive treatment. We really get to know them. And I really see that tension every time they receive their HCG titer. And so, psychosocial effect is great for GTN. It's good that we have a support group. And it's not just the tropang tropho in PGH. There are actually a lot of social groups now. A lot of my patients go there, and it's good because na-uplift yung moral nila when they realize na, oh my God, it's 100% cure rate. It's even with the brain. Imagine, brain mets na, pero more than 50% pa rin ang cure rate. So of course, they would strive hard to reach that. So sa amin lang talagang, ako I always have my line open to them. Kahit na late at night, early in the morning, when they text them, I make sure that I'm available for them because they need it. And of course, I always tell them, if you need psychiatric help, then I will refer you to the best. So that, kasi important yun Dapat alam nilang gagaling sila and they look forward to it so that they will do their best to adhere to our treatment plan.
Thank you very much, Dr. Agnes. Wow, we can go on and on, talk about this. Raymond, wala na tayong time. I think maybe we can pull in 1 or 2 questions on your end. Sige, Raymond, say it na. Sige.
One more question po, and I think it's common. I've seen 3 questions about this po. Meron daw po bang dietary or lifestyle recommendations para daw maiwasan or at least reduce the risk of these conditions? For Dr. Agnes.
Unfortunately, none. Yun ang problema because we still don't know. For HMO, for example, we still don't know why this happens. So if we don't know, we cannot prevent. No, it's just something that happens randomly. Although there are cases where we see patients having hydatidiform mole 2, 3 times, 7 times. I have a patient, 7 HMOs already. Yun po, may genetic problem na po talaga yun. Pinapa-imbestigahan na po namin yung DNA nila, no? And they cannot have a normal pregnancy. But for the majority of cases, there's no risk. We just know it's common for the younger and the older age group. Nothing with the diet. Pilipino lang po tayo. Yun lang po siguro. So early diagnosis is still the key. And I'm hoping that with this, a lot of us became aware of the disease process so that we can really diagnose them early.
Yeah, I guess one day we might find out what's causing it, no? But for the moment, I think it's just great to know that these resources are available, your network, the support groups, and of course, the specialists, doctors like yourselves. Okay, so Raymond, let's go to our, oh yeah, go ahead.
Can I just add something? No, I forgot.
Okay.
There is a society. We have the Philippine Society for the Study of Trophoblastic Diseases. We have a Facebook page. So for those who don't really know what to do, want to have a doctor, you can always message us through that Facebook page so that we can help you out.
Wonderful. Thank you so much. Okay, Raymond, we have to start wrapping up. So maybe let's go to our Q&A.
Yes, well, for our can we have it on the screen for our 2 questions? Vote in the Zoom tsaka dun po sa Slido. Okay, we're seeing the Zoom right now. Okay. Can we go to the first question in Slido? There we go. For the first question, we'll ask the question and I'll point to the expert who talked about it. So, what is the most common presentation of high.DD4 mole, Dr. De Ramos?
Yes, the answer is letter A, no? The most common presentation is vaginal bleeding to as much as about 80% of the patients.
Okay. Thank you, Dr. Febi. For question number 2 is for Dr. Mariel. What is the primary mode? Can we have that on the... Yeah, there we go. What is the primary mode of treatment for gestational trophoblastic neoplasia?
Like what I said in this slide, no, the cornerstone of treatment for gestational trophoblastic neoplasia is chemotherapy.
Chemotherapy. Okay. Thank you so much. So at this point, we'll ask our speakers po to take a minute or two to gather your thoughts, come up po with what you want to serve as your parting words, essentially what you want the audience to take away from this webinar as we move on to the evaluation poll. So for this evaluation poll, we are not sending out a separate one. Ito na po iyon. So encourage everyone to participate in this evaluation poll. There are 5 statements here, 4-point Likert scale, and I'll read through them. And we encourage, as mentioned, we encourage everyone to participate. The poll has started. There we go. The panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we will not be closing this until the end of the webinar as we move on to the final words from our speakers, Dr. Susie.
Okay, thank you so much. We'll start with Dr. Agnes Soriano, Australia, for your parting words.
You're on mute, ma'am.
Mute.
Okay, so again, thank you so much, TVUP, for this opportunity. So as I mentioned in my reaction, the first step towards early diagnosis is recognition and awareness. So I hope with this, we created that. We created a dent and we are able to diagnose the disease early. And of course, the second is proper referral. No, kasi we might know the disease, but if we don't refer to the appropriate people, then management might not be correct. So I hope that with this, we will be seeing more patients so that we can give the treatment to these very young patients with H-mole and GTN.
Thank you very much. Let's go to Dr. Mariel Gammad. Go ahead, please.
Yes, ma'am. For me, GTN is a highly treatable disease. Like I mentioned, it approaches 100%. Again, to emphasize not just awareness, but early recognition, high index of suspicion of the disease would lead to proper referral, timely referral to the experts, and therefore a better quality of life for these patients who have GTN. So like what Ma'am Agnes said, I hope this webinar was able to create this awareness na meron pong sakit na ganito. Therefore, at the back of your mind, it's there already, then maybe there's going to be more recognition of the disease and again, the timely referral of the disease.
Thank you very much. Let's go to Dr. Maria Febi de Ramos.
Yes, I'd probably say the same with my colleagues, but what I want to tell our viewers is that there is a trophoblastic disease referral center, and that's the Philippine General Hospital. Every time you have gestational trophoblastic disease or you don't know where to go, no, PGH is just there to help you. So thank you for this opportunity to promote awareness. And I think my mentors and my colleagues already mentioned about the importance of it. Yan lang po.
Thank you very much to our three wonderful doctors for sharing your time, your knowledge, and we hope that this will support your advocacy and raising of awareness, no, so that people know what kind of resources are out there. So we have a Raymond, you're gonna go to the evaluation first.
No, we'll have the synthesis po muna and then later the
Okay, so we're gonna ask Stella Legaspi Jose to come in. And Stella, thank you for inviting this wonderful group of doctoras. I know you're behind this, so go ahead with your synthesis. Stella, go ahead.
Good afternoon, everyone. Thank you for listening to our webinar, for tuning in. And we had three speakers actually who did very well. Excellent lectures. From Dr. Febi de Ramos, she mentioned that gestational trophoblastic disease is an abnormal growth of the trophoblasts. And the lesions range from benign to malignant. Okay, so when you say hydatidiform mole, you have the complete mole and the partial mole. And she also explained that. So hydatidiform mole is an abnormal pregnancy that results from an excess in the expression of the paternal genes. So galing siya sa male, okay, sa male partner. She also explained yung 23X. Tapos it will fertilize an empty ovum, and there results red duplication of the paternal DNA, so nagiging 46 XX, and then pwede din naman na diandric dispermy, and you have 23X sperms which is fertilized by and enters an empty ovum. Okay, so it was very well explained in her lecture that the risk factors are pregnancy of extreme maternal age, so in the very young and in the very old. So when we say old, that is 36 to 40 years old. And the patient had a prior hydatidiform mole ethnic predisposition. So we Asians are more prone to H moles, no? Asian, Hispanics, and American Indians. And also the diet, they say the lack of vitamin A. She said in her summary that the basis to diagnose H mole is the clinical presentation, the typical ultrasound picture of snowstorm appearance, and the elevated serum beta HCG. She said that the gold standard is histopathology. Now, in the lecture of Dr. Mariel Gammad, she mentioned the classification of gestational trophoblastic disease. So we have the invasive mole and the choriocarcinoma, the central site trophoblastic tumor, and the epithelioid trophoblastic tumor. And what they want to emphasize is that unlike other malignancies, gestational trophoblastic neoplasia is curable. And we also want to emphasize that if you have a patient like this, you can refer them to us in PGH. The Division of Trophoblastic Disease is open day and night. And FYI, for your information, all the medicines, all the laboratories, all the necessary equipments, they are for free. They are given for free for all the patients who go there. And I also would like to acknowledge the forefront of trophoblastic disease in our country, I want to just say Dr. Fe Palo Garcia and Dr. Greg Pastor Fide, they are really the proponents of the Trophoblastic Disease Division, and we salute them in this webinar. Thank you very much. Back to you, Susie.
Thank you so much, Stella. Naalala ko tuloy yung ating mga professors, no? I was thinking of both of them while I was listening to this lecture. So thank you so much, Stella, for that. Okay, Raymond, let's go to our results of the survey.
Okay, mataas-taas po at least 96%, mga 98 at 99 po ang percentage. So very, very well received. A lot of clarity given on several different items on trophoblastic diseases. So really, we're very pleased and very honored po that we have had the opportunity to hear from the experts from the Division of Trophoblastic Diseases of the UPPGH Department of OBGYN. For next week, our sneak peek, Dr. Susie, ano ba meron?
Ako, hindi ko alam eh. Sabi yung cardiovascular, TCVS?
TCVS, yes.
Cardiovascular surgery. Okay, so please be with us next week. A very interesting topic. And again, we bring you the best speakers, so don't miss it. Go ahead, Raymond.
Thank you, Dr. Susie. For those who are asking po, yes, we have we have archived po all 169, and then after today will be 170 po na webinars in the TVUP YouTube channel. So you just open your app and go to TVUP.ph, or you could open up your browsers, go to www.youtube.com/TVUP.ph for you to see all Stop COVID Deaths webinars there. Pati na rin po ang ating SCD shorts po natin. So yung SCD shorts po, these are very, very short consumable videos that you can watch at your own convenience, also found at the YouTube channel of TVUP. So we encourage everyone, if you're watching this in Signal TV channel 101 or sa playback po, we encourage you to please watch this again. Marami po kayong matututunan about trophoblastic diseases. So this formally closes our webinar for the week. Magkita-kita po tayo again next Friday from 12 noon to 2 p.m. It's a date.
Together we can stop preventable deaths.
So keep safe, keep healthy, and see you online.